Thank you, Richard, and I can cut it short anytime. And thank you very much for coming and supporting the meeting. We've been talking about doing this for several years, and we're very excited to get things moving, to actually have a group of clinicians and clinical researchers focused on atherosclerosis. And those of us who are cardiologists know the Cardiac Society doesn't have a big focus on that, so we definitely want to pursue this over time. So just my disclosures, I just need to, just in view of what Richard said, just make it clear when I'm speaking that I'm here as a clinician, and these are my private views and not supported or the views of the Victorian government. So as we've discussed earlier, plaque biology, as many of us, or all of us really in this room know, is not just about lipid deposition, and that's something that we still have to educate our patients about, and I suspect some of our colleagues, and that what we see as clinical events is really related to plaque rupture and thrombosis or platelet aggregation in the wall of the arteries. So as a cardiologist, an interventional cardiologist, and there's several of us in the room, this is what gets us up in the middle of the night, and this is what causes our patients to have events. So although the lipid biology is a significant part of it, I think some of the comments you've heard today about looking beyond that are really important in terms of prevention of events. So in terms of insulin resistance, and I've started to be asked, and I don't know if you have been asked to give talks to our other colleagues, and I'll explain to you why, because other subspecialty areas are increasingly interested in the concept of the insulin-resistant patient. I was just talking to people about Jerry Reven, who described metabolic syndrome originally, who his desk was about a foot from mine when I was in Stanford, and that was, my wife was in his lab. So I actually had spent 3 years talking mainly about sports, which he's interested in, but he has a lot of interesting thoughts about this, and I was just looking at a review article that he wrote in Circulation. He is very distressed that it's been turned into a disease, that the idea that metabolic syndrome is described as a disease is something that he's very concerned about. He writes a lot of articles about this, and he intellectualises this a lot, and it's quite interesting the way he thinks about it, that insulin resistance and metabolic syndrome overlap, but they're not part of the same thing, although they clearly are very commonly associated. And he talks a lot about the idea that insulin resistance increases the chance that you'll have the features of metabolic syndrome which are associated with cardiovascular risk, rather than it being something that you've caught or developed, or it's not a genetic disorder. So anything that clumps it together and that's why he doesn't like the idea. He wishes he'd never used the word syndrome, because he thinks that, which is probably correct, has become a disease that's been fenced off. So in terms of teaching our colleagues how to recognise some of the clinical features that are associated with insulin resistance, adipose distribution, hypertension, macrovascular disorders, dyslipidemia, as we've talked about particularly. And I find, to be honest, even in my own clinical area of cardiology, that many of my colleagues are really not that focused on triglycerides, HDL, for example, and it's not uncommon that we'll do a ward round and I'll be told there's no risk factors for heart disease in this patient, and they have low HDL and high triglycerides and their blood sugar's elevated. So I think those of us in this room can push that idea a little bit further. What's interesting is that there's a range of other conditions that are increasingly associated with obesity and insulin resistance. There's significant loss of life, conflict of interest. My wife's particularly interested in this. She's interested in fatty liver. She'll tell you that it's the commonest cause of cirrhosis in the Western world, and she runs the hepatoma service at our hospital, and it's the commonest cause of hepatocellular cancer and increasing, and it probably also increases the risk if you have hepatitis or alcoholic cirrhosis, and you also are insulin resistant, it increases your risk. And cardiovascular disease, as we know, and the other area, and we saw earlier from the metadata world, I looked over there, you could see that liver cancer and uterine cancer were some of the cancers that are definitely being increasingly associated with insulin resistance and obesity. The other one to mention to you is atrial fibrillation, and much of that interesting work's been done from Prash Sanders in Adelaide, and this is really important work, and all of you are seeing these patients that, although we've seen it come through our door, we've not thought about it this way, that the link between obesity and probably metabolic syndrome or insulin resistance, or however we want to link those things, talk about them, and atrial fibrillation is quite significant. There's clearly a group of patients who have atrial fibrillation who are lean, but then there's a subpopulation of patients who have sleep apnea, atrial fibrillation, and it's been shown now that weight loss can actually improve their atrial fibrillation to the degree where an international editorial suggested that you should be offering people intensive weight loss, which I would argue most cardiologists haven't been doing. So what Jerry talks a lot about is that the best way you can identify who's insulin resistant from your clinical panels is the TG to HDL ratio. And if that's over 2.5, that was highly correlated with insulin resistance. He measures that by variation of a hyperinsulinemic euglycemic clamp called an SSPG, and you can argue about the merits of those. But I've used that a little bit in my own practice as I go through. So he had a big cohort of patients who'd had quite formal testing for insulin resistance, and that was the best lipid surrogate for insulin resistance. Fasting insulin is a key blood test you can look at, but as you know, they're not routinely done clinically, and it's still not very sensitive, and then you can derive some scores that are mainly used for epidemiological studies and other inflammatory assays, oral glucose tolerance tests, and hyperinsulinemic euglycemic clamps, which I'll talk about, which are not really there for research only. We did a study which I think actually was quite interesting, and I'll just show you the abstract in a second, but we did hyperinsulinemic euglycemic clamps on a whole group of patients who were having cardiac surgery. It was a very labour-intensive study. All of them, who all had, starting off, had normal fasting sugar, all of them were severely insulin resistant. So it was only a smallish sample of patients, 22 patients, but at least in that population, it looks like everybody who's turning up to have cardiac surgery who has a normal blood sugar, these weren't diabetic patients, actually had severe insulin resistance measured by the clamp. And we used that to show that then predicted those patients who went out of theatre on insulin infusions and had hypoglycemia after their surgery. And those of us who work in this area will know that this is not an uncommon scenario where patients have bypass surgery and then they come out of the surgery on an insulin infusion, and eventually it's deaf-a-vest and they may well not go home on any anti-diabetic medication. But there's something going on in terms of the metabolic stress, and that's been shown to carry poorer prognosis for those patients overall. The other issue is that in a range of studies, meta-analyses, you can show that new onset hypoglycemia in acute coronary syndrome patients carries a very significant risk of future death and further vascular endpoints. So I would argue too that most cardiology units are not looking at this at all. They're not looking at whether the patients are hypoglycemic when they come through. And that just showed that study that they were non-diabetic normoglycemic patients. They're highly insulin resistant, and it was the preoperative insulin resistance, not the fasting sugar, that was associated with the degree of perioperative dysglycemia. So it's a small study. We're doing a more expanded version. One thing we showed was in that group anyway, the HOMA score actually gave you the same information. So in terms of other mechanisms of risk in patients that we define as having clinical insulin resistance, I'll talk to you briefly about endothelial dysfunction and the role of inflammation particularly. I won't dwell on these, just mainly for those of you who are not very fixed in this area, that there's been data for a long time showing that low HDL cholesterol carries additive risk, as we know. We haven't published yet, but we've got a large cohort study of patients who've had a coronary angiogram, so they're all defined in terms of whether they have coronary disease. And the most predictive feature, so this is a cath lab population, and many of them are on medication, HDL cholesterol is by far the most predictive feature of who has coronary disease in that population. And also it was lower in people who had acute coronary syndrome. So there's probably also an inflammatory element to that as well. And that's why I wonder if some of the genetic disparity you see is that the LDL may well largely be driven by genetics, but the HDL may vary based on a range of other physiological states. Hypertriglyceridemia is another way of identifying risk in this population. This is the distribution of triglyceride levels in the US population. And as we know, and many of you are more expert on this than I am, but for those who aren't, one of the things is that this is something, and I'm now being asked by my patients about this, what can you measure my small dense LDL, and I don't care about normal LDL and all this kind of thing. So it's out on the internet, And I think, again, many of our colleagues, certainly in cardiology, don't really know much about this, and they get nervous when the patients ask them, so they send them to me because they think I know more about it, kind of thing. So I think the patients are beginning to develop understanding, and you may be familiar with the idea, but in terms of risk assessment, patients can actually pay in the US to have NMR studies of the size of their lipid particles, and so there's lots of literature about that. So I think those of us who are interested in this area at least need to know a little bit about it to be able to talk to our patients, but it's definitely not mainstream at the moment. As we've heard a little bit already today, and I won't dwell on this, that prediction of risk is much more than just looking at LDL, and this is an area where people in this room have expertise, and I think part of the role of this group is to disseminate our knowledge and training. I know one of the reasons I'm really excited to put the group and talk to us and see people together is that we can educate our colleagues and certainly our juniors. I'm seeing that our registrars feel very unskilled in the management of lipids, particularly across the board. They're mainly used to treating patients in hospital. So I think this is something that really is needed over time, and especially as we have more diabetics and older patients. And I'm telling them that the main growth area in cardiology is clinical cardiology, which none of them want to hear, and cardiologists, I'm looking at a few over there, we're the cockroaches of medicine, so we'll survive the nuclear holocaust. However, we are getting saturated with procedural cardiologists, so we need to support people to be more interested in clinical cardiology. And I won't dwell on this, but we heard a great series of talks from our colleagues you've heard from their group earlier today, that and Steve showed some of the slides showing a lot of data about non-HDL cholesterol at the Cardiac Society. So I think there's going to be more interest in looking at this as a predictor of risk in this population, and that's obviously including all ApoB containing lipoproteins such as lipoprotein a, chylomicron remnants. So we're going to be educating our colleagues and looking at data in our various populations. I think the other thing is, as I'll talk to you about in a second, those of us who work in lipid clinics, there was a little wave of, and I remember giving a talk with David in Melbourne a while ago, when Omicron was very much on the march. This is the area that causes the most consternation, as we know, but in insulin-resistant patients, this is something that comes up quite a lot, that we are prescribing these drugs to treat hypertriglyceridemia in our patients, and the GPs will put them on statins, as we know, and send them in. This is the only referrals I get in the hospital directly are the patient's got pancreatitis, or they've got a cholesterol of 25 and they're going to have a heart attack straight away, and it's an emergency, can you do something about it? So I think people feel very unskilled in this area, except for those, many of you who are in this room. As we know, there was a lot of literature that came out, particularly out of the Gissi Prevenzione study about treatment of triglycerides, and to the degree where the Cardiac Society guidelines for heart failure actually include, I think it's still current, that it's reasonable to use Omicron to treat patients who have systolic heart failure, based really on the findings of that study. But now others have come through, and there's a lot of contradictory data, and I went to a talk recently at quite a good meeting in Taiwan, actually, where a very well-known expert in the field said there's no good data that treating triglycerides reduces cardiovascular risk. And so certainly some of the Omicron endpoint studies have been disappointing. So I think that it's a marker of risk in this population, but treatment doesn't appear to be we can't say it's got a positive effect at this stage, I don't think. The other thing, as we know, is that it takes a while for the impact on the triglycerides to occur. Phil is not here, but Steve, of course, worked very closely with him. Many of you know him very well, but there's been lots of good studies to show that, again, HDL is a very good predictor of risk in this population, even independent of LDL cholesterol. However, as you've heard already, and I won't remind Steve, but that we're waiting to see the results of the final CETP inhibitor trials, but raising HDL doesn't appear to be beneficial in that way, which is disappointing, but we're obviously waiting to see the results of the studies. So the other thing, which I was just looking at as we go through, if we look at the current status of dyslipidemia and insulin resistance in this setting, what those of us who have some patients with type 1, and you may be familiar with it, was data in FH as well, that having insulin resistance is an additive risk factor to for vascular outcome in these patients. And when I started my PhD with Alicia Jenkins, she was very heavily involved in the idea that there were genetic predictors of risk in these patients, so that some type 1 patients clearly get through life without any vascular disease and some have very advanced vascular disease, and trying to see why that was in the turn of the century, I guess. I think it seems from talking to her and others that there's a bit more of a move towards the idea of the insulin-resistant type 1 diabetic patient, and so there's a study at the moment where they're giving people metformin, type 1 diabetics, for that reason. I think it's reasonable to say at this stage that there's not good evidence, and people here there may be some other views on this, but that the mainstream of evidence we have at the current day is that formally targeting triglycerides, even though Omicron is, that there's approval to treat triglycerides at a relatively modest level, doesn't appear to reduce cardiovascular risk. And there's no current evidence that supports guideline-based therapy for HDL raising to improve cardiovascular outcome. And I won't dwell on this, and certainly many of you diabetologists know more about this than I, but just for the general audience, mixed evidence that blood sugar control improves outcome in diabetes. So if we talk about endothelial dysfunction as a link between insulin resistance and cardiovascular risk, we're all probably hopefully familiar with nitric oxide biology, but L-arginine is the precursor, and nitric oxide synthase, this is endothelial nitric oxide synthase, forms nitric oxide and citrulline, and nitric oxide is a key protective molecule in the vascular system. It inhibits smooth muscle proliferation, inhibits leukocyte adhesion. In the ideal setting is antioxidant, reduces platelet reactivity, and vascular smooth muscle relaxation. So you've heard of the term. It's a little bit contentious about how important it is clinically, but it's seen in diabetes and in a range of vascular disease states. Most of the measurements that you've heard about are mainly relating to blood vessel dilatation in response to hypoxia or lack of obstruction of vascular flow, so it's so-called flow-mediated dilatation, and other functions are not as well characterised or measurable. So David Sellermeyer, who's familiar to you all, I'm sure, was involved in some of this seminal work originally from when he was in the UK, Great Ormond Street. And what was really interesting about this work was it showed that children who had FH had abnormal vascular function in their arms. So that was one of the first times it was described that there was an early vascular dysfunction present in people who had high vascular risk. Less known, but I think a very important paper, and there's a series of papers about this. Certainly many of the more sceptical cardiologists say it's a paraphenomenon, it's not important, we don't think it matters, but there have been some studies. This is using intracoronary acetylcholine, and I was involved in a study in the US. We were in a big transplant centre where we used to routinely do this on patients who've had cardiac transplantation, who have very advanced progression of what's called transplant arteriopathy. And what was anecdotally to me was we would inject acetylcholine and their arteries would close. They'd have ST elevation, so their endothelial function was so abnormal that it would cause the vessel to close. So it definitely occurs in certain people's blood vessels, but with quite a good follow-up, with a pretty reasonable number of patients who had angina, that it was, if you had abnormal, so vasoconstrictor response to acetylcholine, so abnormal endothelial function, you were more likely to have adverse vascular outcomes, and these were cardiovascular outcomes. And this was another study, a similar study, and these are from 2001. This was using the arm response to acetylcholine, and this is sodium nitroprusside. So there is literature. There's not extensive literature, and it's endothelial function literature's probably peaked, I think. There's less of it around. But looking at vascular dysfunction, and there's definitely abnormal in a range of patients who have diabetes particularly, and we can see that that's a predictor of risk in a range of vascular patients. Another potential mechanism for risk in insulin resistance, and this is perhaps where I think the money lies if we can look into this over time, that This is from 1999. It's actually from a range of studies, but this is from the Physicians' Health Study. And what this was looking at was the role of inflammatory mediators, so or markers anyway, highly sensitive C-reactive protein, and certainly if you combine that with a lipid measure, it certainly increases risk. And though many of us have been present in sessions, perhaps the heat's died off a little bit, but I've witnessed the Europeans literally screaming at Paul Ridker in meetings full of 1,000 people, just fighting with each other about the role of CRP and whether it was important. It's coloured by the fact that the Boston group, Paul, has a patent on one of the tests, and so there's all this sort of nasty accusations that go around. But I actually did some of my thesis about CRP, and there's no doubt that if you have an obese female diabetic, their CRP, and I recruited a whole lot of them for my study, their CRP is over 10 in every single patient. So it's highly correlated with body fat, and it's higher in women. So when we looked at that in the genetics we saw earlier today, I think my memory of it is that the genetic contribution to CRP levels is about 30%, and the rest of it is driven largely by obesity. So it's obesity-related inflammation. I'll talk to you about this a little bit more in a second. So there's nothing magical about CRP. Despite that, I tried to do it in my PhD. So these are actually in stains from plaques, and so whether or not it's actually causal, and as we saw data, it may not be according to Mendelian randomisation studies, but it's all throughout the plaque, and these are in foam cells. So it's taken up by foam cells, and at the time I was doing my PhD, I was really keen to put it onto cells and see what's happened, but as the story goes, there was no funding. But the guys at Davis, if you follow this area, have done that, and certainly CRP does a lot of bad things to cells, endothelial cells, in a lab-based setting. But that was, anyway, it got me a paper for my PhD, so I was happy. The other thing that's interesting about CRP, this sort of is the sort of work that Jerry Reaven just hated, the idea that it was a cumulative burden or a disease. But there is quite a lot of literature to show. This was looking at the number of features of the metabolic syndrome and CRP levels. And I think we did some similar work in liver and showed that that the number of features of metabolic syndrome correlated with the amount of fibrosis. And I think how does that apply clinically? If you get someone with the full hand of the metabolic syndrome features, whether we agree with Jerry's view of it or not, but if you have someone who's hypertensive and he's got red cheeks and he's really centrally obese and he's had gout when he was 20 and et cetera, now that I've thought in that way, a lot of those patients are coming in with liver fibrosis. So we screen a lot of them have fibrosis if you actually do that with ARFI or one of the new tests. And a lot of them go on to develop their breast cancer, uterine cancer, things like that. So identifying who's insulin resistant clinically may be useful, and how we do it and what we do about it is the challenge, but I think that there is some value in doing that. Steve mentioned earlier today the idea of CRP-guided therapy in the Jupiter study, and what it showed, as you know, it was a primary prevention trial, and it was based on, and I asked when I saw this presented, they didn't really correct for obesity in that study. So the idea was that CRP's measuring hot plaques, that kind of idea. I'd really dissuade people from that viewpoint. I think the CRP you're measuring it's inflammation that's driven by probably the underlying risk for heart disease, which is obesity or insulin resistance. So I don't think it's measuring hot plaques, but that's how it was sort of portrayed over time in the media particularly. But as you know, it did actually, although the number needed to treat in the study was very high, it did show that if you used CRP to target the therapy, there was some rationale in doing that. And it's actually not PBS indicated, but it's approved by the TGA for that indication in Australia. So is there something is it just obesity-related inflammation, or is it other forms of inflammation? I think the general consensus I would put to you is that it's actually any form of inflammation, so that obesity is the commonest cause, but this is where you can tie together these ideas about infections, rheumatoid arthritis, lupus. All these things have increased vascular events, and there's a range of mechanisms by which that may occur: oxidant stress, endothelial cell damage, matrix metalloproteinases, and these are the substances that we are worried about in terms of plaque rupture. And I won't dwell on it today, but there's a lot of evidence to show that when there's outbreaks of infection in the community, there's more heart attacks. You can actually show vaccination alters your endothelial function. So it may not be specific to any form of inflammation or infection. It may be any form of chronic infection, dental infection, periodontal disease, for example. And that's, as I said, chlamydia. All of them have been associated with vascular disease, influenza and respiratory infections associated with acute events, and some suggestion, although less so, that vaccination is protective. Rheumatoid arthritis, and I've sort of now get asked to give talks to my dermatology colleagues, rheumatoid colleagues, because they're interested in this now. They can show it's associated with excess mortality for 5 to 15 years, similar to what we saw earlier today with diabetes. And it's mainly premature coronary disease, and that's not known. So you have young women who have rheumatoid arthritis in their 30s and 40s. They're going to die 5 to 15 years earlier than they should have, and the commonest cause of it is cardiovascular disease. And so you can show that they have lots of studies have now shown that they have abnormal vascular function. And there's been some interesting studies, this has been around for a while, showing that they share a phenotype in terms of their inflammatory cells with patients who have acute coronary disease. Again, I would argue that it's probably just general, and now we know more, it was any form of inflammation rather than being specific to rheumatoid arthritis. So in immune diseases, there's chronic inflammation, there's altered lipid profiles and function, but I've always wanted to do these studies, but there's not an extensive, when I've tried to look it up, there's not an extensive body of literature looking at the effects of severe inflammation, sepsis, on a lot of the things we're interested in this room. And as we know, you'll go to ICU to do a consult on someone who has sepsis, for example, and they'll have severe hypoglycemia, but they may well have hypertriglyceridemia and often low HDL. But I think there have been a few studies, but it's an area where it'd be interesting to do more. They have autoantibodies, T-cell dysfunction, and there's this interest in the idea that there's autoantigens that have been detected. And this is where, if you've seen literature about heat shock proteins, which may lead to molecular mimicry and so forth. And so those of us who, if you've had an interest in this, the idea that, for example, if you have an infection, that the immune system is triggered off to lead to some sort of form of autoimmunity by confusion, if you like, of the immune system for heat shock proteins and self-antigens. So this, I won't surprise anyone to show you this, the burden of, a growing burden. It's Paul Zimmet there as an author. Zinnet was wrong, sorry. That wasn't my spelling. But as I mentioned before, I think everyone in this area will talk to you about the idea that we're not really good at sub-defining the racial issues, and I think that is a really important feature, because all of us work in different parts of Australia. As you know, that patients from the subcontinent have extremely high rates of insulin resistance. I've started consulting in an area where there's a lot of Filipino patients who I used to see a lot in the west coast of the US. They have very, very high rates of insulin resistance, and they're not big people, as we know. So there's clearly huge racial variation. So a lot of the data we get is a clumping together of a group of people, and we don't know enough about the subgrouping. And I didn't really know this until I went to the US, that African Americans and Africans tend to be not so centrally obese compared to other races, but they have very much higher hypertension and they have very much higher left ventricular hypertrophy. They get very thick ventricles. So there's clear differences that are racial, but I think if we're starting to talk about these things, we have to start breaking the patients down in a bit more of a sensible way, so we're not comparing a 5-foot-tall Asian with a 7-foot-tall African patient, because they're so different phenotypically. So one of the things I really point out to my colleagues when I give talks about this is, although diabetes is a known risk factor and they certainly accept that, they're not always aware that impaired glucose tolerance and impaired fasting glucose, although not to the magnitude, still carry significant risk above that of patients who have normoglycemia. And so the identification of this is valuable in terms of risk stratification. And to those of you who are diabetologists, you'll take that as being completely sensible, but certainly in the cardiology world, most of and cardiac surgeons, although their patients have hypoglycemia, they tend not to worry about it or focus on it. And so they certainly will I've challenged them, and not uncommonly the patient will have a fasting glucose of 6.3, They don't really focus on that, and then you're relying on the GPs to focus on it. But I think we need to lead in that area, and there are guidelines about performing oral glucose tolerance testing, of course. So in terms of where the inflammation is coming from, why is it happening, this I think is worth mentioning to you, and that the prevailing belief is that, and TNF-alpha for the endocrinologist, diabetologist amongst us is something that you've certainly heard a lot about, but the CRP we believe that we're measuring in the bloodstream in these patients is largely driven by fat cell induced inflammation acting on the liver, and it is one of a range of inflammatory mediators. And so you can list a whole series of inflammatory proteins, and they're all elevated in obesity. So there's nothing specific. CRP is useful because it's a very stable protein, so you can leave it on the shelf overnight. You don't have to freeze it straight away, and it's easy to assay with a relatively cheap test. So that's part of the reason why it's taken off in terms of popularity. But there's a whole series of other proteins, cell adhesion molecules, and interleukins that are also carry similar prognostic information. And then there are a range of other fat cell-derived proteins that have all been implicated in cardiovascular disease. Leptin is one, adiponectin, and so each of them sometimes gets presented individually. And if you're not sort of made aware by the authors that it's actually related, I think it's more understood now. But when it came out, they were being pulled out in isolation, and people would read a paper saying adiponectin's associated with heart disease, but in fact they're really just a suite of proteins that are abnormal in patients who are obese. So leptin is interesting because it stimulates the sympathetic nervous system, so it's been implicated in hypertension as well. And as we know, there's a state of leptin resistance in patients, almost all obese patients. And there's actually receptors on the platelets for leptin, and no one actually knows what they do. Adiponectin levels are low in obesity, and there's been many vascular actions demonstrated. And there are a whole range of other proteins that, as I said, are related to fat cell inflammation or generated inflammation. I'll just talk a little bit about TNF-alpha, which I think is interesting. Interleukin-6 is probably the other one that has had a lot of literature about it. So TNF-alpha is a very interesting story, and I won't dwell on it today, but as Steve has been involved in many of the studies, that using anti-inflammatory strategies hasn't been particularly productive so far. There's quite a few Australian investigators, including us, are looking at colchicine to prevent vascular disease outcomes, so we'll see what happens there. But TNF-alpha is known as cachectin. It's a key regulator of endothelial biology, and what was interesting was TNF-alpha knockout mice had severe heart failure. And so then people were very excited because there was an antibody that was being used clinically that was useful, very useful in Crohn's disease and rheumatoid. It turns off inflammation. Okay. Sorry. And, okay, bad heart failure, no worries. Okay. So very quickly, what they basically found was that TNF-alpha blockade actually made patients with heart failure worse, and so that's killed that story. So it's very disappointing because you could actually show all the way up to the story of actually giving it to the patients that it should have been beneficial. But that was using an anti-inflammatory strategy with an existing, so I'll jump through that quickly. So just as a final couple of slides, that heart failure, that's the other emerging area that I mentioned to, that insulin resistance. So when I was at Stanford, they published a range of studies showing that the patients who had, these are patients who have idiopathic cardiomyopathy, they are much more insulin resistant than controls. And as I said, it relates to atrial fibrillation and sleep apnea. I'll jump through that, sorry. And just in terms of what we can do about it, I know David will be very happy this gets a mention, that what can we do with our insulin-resistant patients and whether there's any specific strategies. And it looks like the Mediterranean diet, which we know is a good, it's been shown in primary prevention studies and the PREDIMED study to improve almost every cardiovascular risk factor. And those studies are really interesting. There's a lot of papers out of them. We just did a small study, which actually was probably of all the things, it's in the liver literature, so I don't know, and I didn't get much kudos out of it. However, this is actually quite a good study. It was very small, but we did clamps and went to a lot of trouble and actually showed without weight loss, the fatty liver went from, some of them have 90% fat in their liver, down. It had a huge impact on their amount of fat in their liver. So the liver fat people think this is really interesting, and it also improved their insulin resistance very significantly. So that's one area where there might be some therapeutic strategies to target insulin resistance in our patients. So I might stop there. And that's the heart attack real.
Thanks very much, Andrew. We've really only got time for a couple of questions, but I just want to ask you, the heart failure stuff's really interesting.
Yeah.
And Diana's big data talk, heart failure was a very prominent issue in diabetes. Any theories on the mechanism?
So, well, I think TNF-alpha would be one, maybe, but I think that all of those fat cell proteins that we whiz through quickly, if you have hyperleptinemia, you can make a case that it's sympathetic overdrive, there's fluid retention, there's renal effects, there's a lot of those inflammatory proteins are toxic to the heart. So I think it's not...